Many thanks for staying with the big story. And tonight we are talking about that move to import doctors from Cuba. And Dr. Ochanji, let me stay with you for this one, because the ratio of a doctor to patients in Kenya at the moment is 1 doctor to 17,000 Kenyans against a World Health Organization recommendation of 1 to 1,000. So what would baffle many is how, with this kind of big discrepancy from what is recommended, that we still have specialists and doctors who are unemployed?
That's a big question without an answer, because we have specialists who've gone to given counties seeking to render their services, and they've been rejected. We have cases where, as close as Naivasha, a specialist will go to offer services having been trained, and then on the basis of quote-unquote budgetary factors, they're not given the priority. We have, as I had mentioned, close to 1,600 locally trained medics who are not working. And so if we're looking for ways of narrowing the gap, the best way and the best practice is to employ the doctors, and then at the apex, release those who've worked for 2 to 3 years for training. So as you train more, you absorb more. But the current scenario is a case where the counties are not releasing doctors for training. They're not absorbing new graduates. As a result, those who want to go for training, and it's their right to go and enhance their skills, they're forced to resign from those jobs. Mm-hmm. So you find a case where counties continue having lower and lower in terms of the number they're supposed to be having, as opposed to having more to bridge the gap. And I heard our good Madam CS talking about mentorship. And one will beg to ask, how will you mentor if you've not absorbed others? The best practice will be absorb more and then bring foreign doctors, as they may be, to mentor these young ones. Mm-hmm. This is a case of bringing doctors who are supposed to be providing mentorship, but you have not employed. So how will they be mentored? It's not very clear.
Right.
Again, it's the other thing I want to put across is it's not true that Kenyan doctors do not work in far-flanked areas. We do have doctors working as far as the Dadaab. Those working in the Dadaab, they work there because the conditions provided there are favorable for them to work. You'll find that a nearby government-owned facility does not have doctors. Yet in the Dadaab, equally far-flanked area, there are doctors working there simply because their conditions and the environment of work is way better than that of the government. So that lies the answer to that particular question. Right.
And Mr. Maleche, it would appear that really this all boils down to what seems to be bad blood between the government and, doctors in the country and health governance in general. What do you think would be the approach? Where do we start? Because both parties are very important, and the person that really, suffers between this, in this entire situation, is the Kenyan who needs to access healthcare.
Sharon, I wouldn't call it bad blood. I would call it lack of transparency and accountability. And I think where we need to start is holding institutions accountable. One of the things I wanted to mention earlier was the fact that what is the role of the Kenya Medical Practitioners and Dentist Union, because they are the body which is mandated to license foreign doctors to practice in this country. Could they share the minutes where they made the decision to have the Cuban doctors? Could they demonstrate that due process was followed? And that's where we start to find out, are institutions really working? Mm-hmm. So in my view, and I said it before on a show earlier on here, that we need an independent audit of the health system to clearly understand where are the gaps at the national level, where are the gaps at the county level, and this independent audit must be done in a transparent manner so that we all have some level of agreement as to where the gaps are and what then is the action plan that could be prepared. This has happened. We have seen the Parliamentary Health Committee when we had the fiasco of operating the wrong person on the brain. They did an audit of the systems at Kenyatta Hospital. Despite finding the wrong things, their recommendations were not in par with what would have been the rightful action plan to get this forward. So we need more audits of that nature, but they need to be more participatory, and we need to ensure that the plan of action is very specific and can be monitored by different stakeholders and players. And of course, most importantly, we must seal the loopholes of leakages and corruption in the health sector. There are too many, and this is costing us a lot of money. Thirdly, I would say the issue of right to access to information remains a major challenge for our health sector. Mm-hmm. We make a lot of requests for information for documents, including this MOU with the Cuban doctors, but the Ministry of Health is never responsive. We've previously asked for intergovernmental agreements between the national government and county government on issues of health. That has never been made available. So if we address the three things of having an independent audit, sealing loopholes for corruption, and being more transparent and sharing information in decision making, we will then be walking to the right path to trying to make healthcare affordable, accessible, and acceptable to the Kenyan citizen as is envisioned in the Constitution of Kenya at Article 43.
Right, and let me stay with you, Mr. Maleche, because what everyone seems to be agreeing with is that what is working for Cuba is their healthcare system. Not necessarily that we need to bring their doctors, but we need to perhaps emulate some of the things that are working in their system. One, that it's entirely free, and second, that their citizens can access comprehensive healthcare from a very low level of the hospitals. Are these some of the things that we could aspire for our healthcare, and is it possible for us?
I think it's not something we have to aspire to. It's something that we legally have to do because the Constitution obligates us or obligates the governments to provide the right to health to citizens. I think the lessons for those who went to Cuba, and I hope they will share that with us, is that the Cuban government did make heavy investments in the health sector. And again, they try to address a number of the things we're talking about, including sealing leakages. And so for that to happen, we totally need political leadership. We need commitment from those who have been placed in decision-making positions around decisions on health. We, of course, are appreciative of the efforts made by the head of state in terms of making healthcare a priority. But I think the problem then becomes with the execution of the intention by the head of state to either make healthcare accessible or affordable. So it is achievable. We just are not doing what we expected to do in line with the Constitution and in line with the policy documents that we have put into place. And this onus falls squarely on the Minister of Health and the 47 governors and the 47 CECs of health, who must work with their counterparts to ensure that the right to health is delivered to the Kenyans as required by the Constitution almost 8 years after we adopted the new Constitution.
Right. And Dr. Ochanji, to what extent has the devolution of the health function really made Kenyans have increased access to healthcare? Has it worked? Is it working so far in terms of having even local hospitals better equipped?
Devolution has gone two ways. There are good sides of it, definitely. But the greatest challenge has been the way the human resource aspect of it has been handled. We've seen cases where there's a lot of discrepancy in terms of how they're paid, how they're released for in-house training, how the transfers has been done, and so forth and so forth. In terms of promotions, you find an officer stagnating in a job group maybe for 5, 6 years. And so those are the hindering things. That is, in as much as devolution is good, they've come to, overshadow the all good aspects. And so as a body, we've always advised that if we could have a way of having a centralized way of addressing human resource, because that is the greatest challenge when it comes to devolution. Because counties, the way they are designed, they revolve around a political system where naturally they are glued towards a system of parading projects that people can see. Unfortunately, when you're looking at health issues, most of the budget are recurrent expenditure that goes towards human resource. And so it's not so lucrative. They'll tend to go towards road, buildings, and even if it's hospital, put up structures and theaters, something that people can see. And we want to challenge them that some of the expenditure you do in health may not be necessarily be seen by the people, but they'll help in going a long way to curb the illnesses, mortality rate, make sure that the level of awareness in terms of health is higher. And so devolution is a good thing, but the challenge is the way the human resource has been handled. And the other thing is the governors think that we always oppose devolution. We are sons and daughters of this land. We want a working healthcare system. Encouraging public participation is very good. Sometimes we have ideas that can really help them to overcome the challenges they face every day. And so by bypassing us and going for unilateral directions and decisions always affect service delivery, because at the very end, whoever will attend to the patient must be a doctor, who is trained, must be a nurse, must be a technologist, and is the bearer of the skills. So by passing these people and arriving at a decision that affects them eventually is the biggest mistake that our leaders sometimes do.
Mm-hmm. And Mr. Maleche, Cuba spends up to 27% of its GDP on healthcare, compared to Kenya, which spends just about 2.8% on the same. Do you think this definitely has implications on just how effective the healthcare would be? Does it speak to the kind of weight we are giving as a priority to healthcare in the country?
I think the issue is not about, of course, it's important to put resources in the healthcare system, and making a flat comparison between what Cuba has put in the health system and what Kenya has put vis-a-vis their economic power may be a bit arbitrary. But what we know is that we cannot tell for sure how much money goes to the Kenyan government, be it at the national or the county level, in terms from the budget, in terms from donors, and most importantly, to what extent is that money used efficiently. So my clarion call would be that we first need to be able to understand clearly how much money is going into the system, how is it being utilized, and what is then the need, so that we cost our healthcare based on the need that we have in the country and not based on arbitrary figures based on either what Cuba did or what Rwanda has done. We need to understand what is our unique situation as Kenya, what are our health needs, have we costed how much each service is needed, have we costed how many people need that service, and then we work on a budget based on the costed need of the country. That is what we are failing to do, and that is what is leading to us shooting and missing the target of having adequate resources for health, which are well managed and are not lost through corruption, eventually affecting the poor citizen or children who cannot get vaccines because money has been embezzled. So this is critically key for the Ministry of Health, for the 47 CECs to show leadership by costing what is needed for their counties on human resource, on services, on commodities, and making this process participatory so that they can get as much feedback as possible and get ownership even from those who use the health system.
Right. And I want to stay with you, Maleche, because some say that what is making the cost of healthcare expensive for us here in Kenya is because we really, most of the time we diagnose the diseases very late. We don't have a strong preventive care, whether it's awareness or access to get treatment at an earlier stage. How can we change this narrative so that we strengthen, access, we strengthen the idea of preventive treatment?
I think it's true we have invested and focused more on the curative piece, where we prefer to see people at the hospital instead of taking preventive measure. And I think the answer to this lies in the leadership we need to see in the policy documents that are made by the Ministry of Health and the 47 county governments. We need to see how well they have spread their budget between prevention, curative, palliative care. We need to see how well they're balancing around those particular issues. But I do agree with you that more emphasis should be taken in terms of prevention, and even as we still scale up investment in the curative perspective, the aspect of prevention is quite clear because it will help save us a lot of money. Instead of having people sick on the hospital bed, if you take measures to either get people to sleep in a mosquito net, if you get people to take malaria prophylaxis, then you're making gains that ensure that people don't fall sick and lose man hours lying on hospital beds and not being productive. So it is critical for us to ensure that we balance all four important aspects of healthcare within the country.
Right, and Dr. Ochanji, the Cuban doctors who are expected to come to the country, the CS says that they will also help train and motivate and mentor our doctors. Is this something that you think would be helpful?
Mentorship and training is very critical, but it will not happen under the current setups because the Cuban doctors who are coming, the areas they're being deployed to are not training centers. And even so, the guys and the colleagues they'll be working with, they'll get just a handful because those who are not being given opportunity to go and train, they live on their own. And so the few that are there, either they're demotivated or the circumstance within that center might not allow them to have that training per se. It will have worked if these Cuban doctors were being deployed in training institutions and training centers. And as a matter of fact, we do continuous training on a daily basis. When we do our ward rounds in Kenyan system, it's usually a nice, smooth mixture of a consultant, an officer, and young colleagues who are the interns. And so in that process, there's continuous education and training that always goes on. When one wants to go and further their skills, the counties and the national government must come up with a way of releasing that person to go and train. And the beautiful thing is that when you go and train, they're usually bonded. That is if they are given training by the national or county government. They're bonded to that particular station. So when they're done with that training, the only thing they need to do is to come back to that particular county and offer their services. But this is not what we're seeing because training itself for medics, they take time. Some go for 4 years, some go for 5 years. And you must invest in those training for you to have those specialists. When your house is leaking, you don't run to the neighbor to get refuge there. You fix yours. And so the whole idea of running to Cuba is not the best way to fix our problems. And the other thing I'd hoped our guys who went to Cuba would have borrowed, and has been partly mentioned by co-panelists, is that Cuba mostly focuses on preventive medicine. And that's why they have very many family physicians who are attached to the families. Ours, we focus more on the curative, and that's why the cost of medicine in our country is so high. And so we need to have specialists who can, for example, manage the equipment that were brought by the medical equipment schemes, as opposed to just bringing family physicians who are focused more on the preventive aspects. And then the other thing that should happen when it comes to the issue of training, when you release an officer to go and train, you must give them room to come and give that skill to the young ones who are in those particular stations. As it is right now, a person comes back with skills, he has trained, but is not allowed. In fact, that is where the discrimination comes in. He goes to a particular county, and then for some weird reason, they're rejected. They should be allowed to come and share that skills they went to learn with the young colleagues who are working in that particular station.
Mm-hmm. And the question is, why has KMPDU as a union, why did you not petition against this earlier as a union?
The thing is, our government likes to work a lot in secrecy. We engage our government every day. But things come at an advanced stage when you cannot do anything. We learned that the leadership of AFIA was already in Cuba, from what we heard from the media that they were doing benchmarking. When at our level, we were still thinking this is a consultative process that should encompass all of us. Mm-hmm. The issue of employing Kenyan doctors, we've been on this for now 2 years without response. The issue of the 171 specialists who have not been absorbed, it's not a new thing. And so even if you were to go to the leadership of affairs today, they have those facts, the number of meetings we've attended, but sometimes somewhere along the way, these factors are never taken into consideration. And as a country, it looks that we react more to crisis than setting down an agenda and solving things the way they come.
Right. Right. Many thanks, gentlemen. We have to wind up our discussion right there, but I want to thank you for joining us in studio tonight. Two Allans, Dr. Alan Ochanji, who's the Deputy Chairperson of the Kenya Medical Practitioners, Pharmacists and Dentists Union, KMPDU, and Alan Maleche, who is the CEO of KELIN. KELIN is the Kenya Legal and Ethical Issues Network on HIV and AIDS. Many thanks, gentlemen, for having come to studio tonight, and thank you for watching and for participating in the conversation. I see some of your engagements on Twitter. Let's keep doing that on that platform, and I'll see you again tomorrow. Have a good night.